Today the topic is on pre-prosthetic surgery. Coming on to the introduction, prosthetics is a replacement of missing teeth, and pre-prosthetic surgery offers significant contribution by removing the hindrance for prosthetic stability and retention. Suppose it can be removal of bony atrophy, soft tissue hypertrophy, localized soft tissue and hard tissue problems. So coming on to the definition as per the GPT, pre-prosthetic surgery is defined as a surgical procedure designed to facilitate fabrication of prostheses or to improve prosthodontic care. And its objectives are to improve the masticatory function, reconstruction of acceptable dental and facial aesthetics, creation of broad ridge form for denture and implant, adequate fixed soft tissue over denture bearing area, adequate vestibular depth for proper intra-arch relationship for protection of neurovascular bundle. And the ideal edentulous ridge should be adequate bone support for denture. Bone should be supported with adequate soft tissue. It should not have any undercut or sharp ridges. There should not be any bony or soft tissue protuberance. It should have adequate buccal and lingual sulci depth. It should not have any scar band that prevents normal setting of denture, no soft tissue hypertrophies or redundancies. And the residual ridge resorption classification, according to Cavod and Howell classification, we can classify it as class 1, class 2, class 3, class 4, class 5 and class 6. On class 1, the ridge will be dentate, teeth will be present in it. In class 2 classification, it will be immediately post extraction happening, and in class 3, after the post extraction, the ridge will be in well rounded ridge form, and after a longer time period without any prosthodontic rehabilitation, it will become in class 4 situation, that is a knife edge ridge form, and further it will become class 5, that is flat ridge form, and the height of the ridge will be very much lower, that is a class 6 situation, and it will be in a depressed ridge form. Coming to its indications, it will be complete or partial edentulous secondary to early tooth loss, naturally occurring reduction of residual bony ridge. There should be any kind of pain, dysfunction, disappropriate growth of jaws, and it's contraindicated in medically compromised situations and in bony disorders like osteoporosis, ossifying fibroma, and bronch, that is a bisphosphonate induced osteoradionecrosis, history of head and neck radiation. So these all conditions, these surgeries are contraindicated. And facial evaluation is very important, that is the case history, the chief complaint, expectation of the patient from the processes, aesthetic goal of the patient, the systemic goals, that all are very important. Intraoral, extraoral oral examination, evaluation of the supporting hard tissue, hard bony tissue, soft tissues. So coming on to the different methods of pre-prosthetic surgery, on its classification there is hard tissue surgeries as well as soft tissue surgeries. On hard tissue surgeries, so these are the basic pre-prosthetic surgery, that is the frenectomy, alveolar ridge contouring, tori removal, soft tissue abnormalities, immediate denture surgeries, and advanced pre-prosthetic surgeries like mandibular or maxillary ridge augmentation, alveoloplasty, vestibuloplasty, and oral implantology. So coming on to the pre-prosthetic surgery classification, procedures for the alveolar ridge preservation, that is supramucosal vital root retention, submucosal vital root retention, and procedure for alveolar ridge correction, that is alveoloplasty, tuberosity reduction, tori correction, exostosis reduction, myeloid ridge reduction, and procedures for alveolar ridge extension, vestibuloplasty, and procedure for alveolar ridge augmentation, that is a bone grafts augmentation, pedicle bone flap. So coming on to the alveoloplasty, there is primary alveoloplasty is there and secondary alveoloplasty is there. So in primary alveoloplasty or simple alveoloplasty, usually done after the extraction of the tooth, we'll compress the socket with a finger pressure. The finger pressure as the tooth bearing area will be edentulous. After compressing the buccal and the palatal socket, it will be reduced. And coming on to the Dean's alveoloplasty, it is same like simple alveoloplasty, but in this procedure what we will do, the interdental bone we will be reducing, and in that area we will compress the socket. So multiple tooth extraction after reducing the interdental bone area, we will compress together and all of the ridge will get reduced. So there can be multiple bony protuberances can be present if alveoloplasty is not properly done. So that's why we are doing it. And in obligaceous modification of Dean's technique, what we will do means, in Dean's technique we are doing the interseptal bone we are reducing, but in obligaceous modification what we are doing, after extraction, the apical area, apical, palatal as well as labial bone, we are making a cut with a specific designed burr, and we are down fracturing it using the elevator, and we are compressing the socket and suturing it together. So the bulkiness of that area will be reduced and we will get a round, good rounded ridge after the extraction. Next is tori removal. It's a small developmental anomaly, can be seen in mandible as well as in maxillary areas. Maxillary mostly seen in palatal areas and mandibular mostly seen in lingual areas. And indications, it can interfere with the daily functional habit of the patient. Patient may be fear of whether it can be a malignant or not, or denture care interference with the fitting of the denture. Coming on to the techniques, the procedure is done under local anesthesia. Preoperative impression should be taken. The incisions preferred as are a Y incision or double Y incision. And in mandibular tori, it's an exostosis located in buccal or the lingual aspect of the mandible. Mostly we'll do it in a crustal incision, and we'll expose the tori area and we'll remove it with a vulcanite burr, a rounded burr, and all of the tori is removed, and afterwards the area is sutured properly. And genial tubercle reduction is also a preprosthetic surgery method. So here we will expose the genial tubercle area in the mandibular lingual surface and we will reduce it. And maxillary tuberosity reduction, the causes can be a prolonged retention of maxillary third molar, enlargement of maxillary antrum, gingival fibromatosis. Coming on to the frenectomy, so this is very much common in young individuals. Mostly it can be a complaint, mostly due to midline diastema or a tongue tie related thing. So frenum is a fold of tissue or muscle connecting the lips, cheek or tongue to the bone. So techniques are simple excision. So we can do a Z-plasty or localized vestibuloplasty. Laser assisted frenectomy also can be done. Most commonly done is a labial frenectomy, and these are the steps. We'll locate the labial frenum and we'll cut, we'll have a clamp with the help of a artery forceps superiorly and inferiorly, and we'll cut using a 15 size blade scalpel, and we'll get a rhomboid shaped space there, and we'll suture it tightly. And midline, all of the midline diastema cases, the middle area, they will be having a thicker tissue. That tissue should be excised, that fibrous tissue should be excised. And in lingual frenectomy or normal